Good day, everyone, and welcome to our YouTube video. My name is Gareth, and today we'll be talking about osteokinematics with an example of osteokinematics. So, to understand osteokinematics, so this presentation will serve as an introduction to how human bones move along visible parts and how physical therapists evaluate this movement in a clinic. So, you need to understand the difference between osteokinematics and arthrokinematics. Osteokinematic focuses on gross movement of bones relative to cardinal planes of the body. Like it focuses on it is the large visible voluntary movement of bones, relative to the planes, like your bending of your elbow or your leg when you kick. And then when we go to arthrokinematics, it focuses on small involuntary movements occurring directly at joint surfaces. So this includes your rolling, your gliding, and your spinning. So there are three cardinal planes of motion. Bones move through three invisible planes, each turning around a specific axis. The first one is your sagittal plane. This is the plane, or it's the plane that divides the body into right and left halves, and movement occurs about medial lateral axis. These include your flexion and your extension. The second one is your frontal plane. It divides the body into anterior and posterior halves, and movement occurs about an anterior posterior axis. This is like your abduction and adduction. And then the third is your transverse plane. This is, or it divides the body into upper and lower halves, and movement occurs about vertical or longitudinal axis. This includes like your internal and external rotation. The third, or moving on, we're going to talk about joint mobility or the degrees of freedom. So joints are classified by how many planes they can safely move in. First degree or 1 degree, which is your uniaxial. This is movement in only one plane. For example, the elbow joint, which can only do flexion and extension. And then 2 degree or biaxial, this is your movement in two planes. For example, the wrist joint, which can do flexion, extension, ulnar and radial deviation, which is your side to side. And then the third is the third degree or 3 degree, which is the triaxial. This is movement in all three planes. For example, the shoulder and the hip, which are ball and socket joints. So we're going to be looking at the example, which is the shoulder joint, which is a triaxial range, basically, or uh, triaxial joint. So the maximum movement of the shoulder joint or the glenohumeral joint, it sheds areas of structural stability to give the body's maximum multi-directional movement. And its movement is, or the movement that can occur at the glenohumeral joint. They include abduction, adduction, which occur in the frontal plane, flexion, extension in the sagittal plane, and rotation in the transverse plane. And then when it comes to the clinical aspect, to lift your arm all the way over your head without pinching tissues or causing impingement, the humerus bone must automatically rotate externally. So, coming to the clinical and field classifications, when a therapist stretches a joint to its absolute limit, they feel a specific sensation called an end feel, and this tells you what tissue is stopping the movement. So, the first one is hard or bony. The sensation is abrupt or solid stop, like for example, your elbow extension. And then the second one is your film or capsule. These are like your leathery stretch with a slight give, for example, like your shoulder external rotation. And then the third one is your soft or approximation. This is your soft cute stop, or flesh to flesh, where your flesh meets flesh, like your elbow flexion basically. And then the fourth one is your empty or your abnormal infill, where there is no mechanical limit or mechanical stop. The patient begs you to stop due to severe pain. Moving on to the physiotherapy applications uh, or the assessment. The first, the first thing that a therapist uses is usually a chronometer, to measure the active and passive joint angles. The second one is your manual mobilization, where your therapist uses tiny passive accessory glides on a target capsule to fix the restricted bone part. Then the third one is your neuromuscular re-education. This is training a patient's muscle to pull smoothly along the correct joint axis, reducing painful grinding. So this is all for our presentation. And for references, is our references or our books that we read to get more knowledge. Thank you.